Welcome to this episode of Myeloma Made Simple. Today's topic is drug classes made simple. One of the reasons why patients are living longer than ever with multiple myeloma is that we've developed so many new drugs to fight this disease. This has been a result of incredible amounts of research all across the world to develop these new drugs. We are going to review major drug classes in multiple myeloma. I will review the basic mechanism of action for each class, along with a brief overview of the benefits and the risks of each. But of course, I cannot provide every detail, so this should be discussed with your provider. Many of these drugs will be covered in much more depth in future episodes of Multiple Myeloma Made Simple. Arguably, the oldest class of drugs we have in multiple myeloma are called alkylators. This is a more traditional form of chemotherapy that has been used in both low-dose and in high-dose forms. There are two key drugs in this class, melphalan and cyclophosphamide. There is also a third drug that is partly an alkylator known as bendamustine, but as it is not routinely used in multiple myeloma, we will not address it. We use melphalan in very high dose when we give an autologous stem cell transplant. We also use it in lower doses, either by pill or intravenously, typically in patients not going to transplant. Cyclophosphamide is used either by pill or IV in combination with other drugs to treat myeloma. Sometimes we use cyclophosphamide to help mobilize stem cells to collect them for transplant. These drugs have significant activity in myeloma both alone and in combinations. But they do, of course, come with risks. They can cause nausea, as well as reduce blood counts as typical chemotherapies do. This can increase the risk of infections, cause fatigue, or bleeding. Furthermore, we know that exposure to melphalan can increase a patient's risk of developing another cancer, namely leukemia. The second major class of drugs are called proteasome inhibitors. These drugs work by inhibiting something in the cell called the proteasome that is responsible for processing certain proteins in the cell. When it is inhibited, those proteins accumulate and the cell will die. This is particularly important in myeloma, where the proteasome may be even increased in its activity, so inhibiting it becomes critical to the death of the cell. The commonly known proteasome inhibitors that we use include bortezomib, also known as Velcade, ixazomib, also known as Ninlaro, and carfilzomib, also known as Kyprolis. These drugs are highly effective and can be used as single agents, but also typically in combination with immunomodulatory drugs, monoclonal antibodies, and literally all other drug classes. Bortezomib can cause neuropathy, typically numbness and tingling in the feet or hands. Ixazomib can cause stomach problems like nausea and diarrhea, and carfilzomib can cause high blood pressure or other cardiac issues. All drugs in the class can drop blood counts and are associated with an increased risk of shingles, so viral prevention is necessary. We use proteasome inhibitors in all phases of treatment for multiple myeloma. The next class of drugs are known as immunomodulatory drugs. As their name indicates, they not only directly affect myeloma cells, but interact between those myeloma cells and its environment. They act on a molecule known as cereblon and can also be used either as single agent or in combination with other classes. The three immunomodulatory drugs include thalidomide, lenalidomide, known as Revlimid, and pomalidomide, also known as Pomalyst. These drugs are all given orally and have differing side effects. We see primarily neuropathy, fatigue, and constipation with thalidomide, whereas with lenalidomide we can see fatigue, low blood counts, diarrhea, and muscle cramping. Pomalidomide is very similar to lenalidomide in its side effect profile, but we tend to see a little less diarrhea. All three drugs are known to be associated with blood clotting, and so patients should be on something to prevent blood clots, such as aspirin or a specific anticoagulant. We use immunomodulatory drugs in all phases of treatment for multiple myeloma. The next class of drugs are known as monoclonal antibodies. This is really a form of immunotherapy where we can employ a patient's own immune system to destroy their multiple myeloma. It is called monoclonal because it has a target and is an antibody because it acts much like our own inherent antibodies that are designed to attack things that could cause harm to the body. Much like when you give a vaccination, your body produces antibodies to that disease, we now create specific antibodies to target the myeloma cell. These antibodies target something on the surface of the myeloma cell that it can hook onto and then trigger the immune system to help destroy that cell. They're Y-shaped so that the open part of the Y can hook onto the cell, and the other bottom part of the Y triggers that immune system to help destroy the cell. Sometimes we call this targeted therapy, as it is specific to the myeloma cell and not to the healthy cells around it. The key targets we use in myeloma with monoclonal antibodies include CD38 and SLAM-F7. We have two monoclonal antibodies that target CD38, daratumumab, also known as Darzalex, and isatuximab, also known as Sarclisa. We have one monoclonal antibody that targets SLAM-F7, elotuzumab, also known as Implicity. These drugs can all be given intravenously, although now there is a subcutaneous form of daratumumab. These drugs are generally well tolerated, where the greatest side effect is during the first or second dose, when patients can have a reaction to the administration of the drug, sometimes called an infusion reaction, for which patients are given medications before to prevent them. They're caused by the immune system overreacting to the presence of that antibody in the system. They can also drop blood counts and can increase the risk of shingles, so antiviral prophylaxis or prevention is given. These drugs are extensively used in all phases of myeloma treatment, typically combined with other classes. One of the newer classes of drugs are called XPO1 inhibitors, of which we have one drug, selinexor, also known as Xpovio. These drugs inhibit a pathway out of the nucleus, the XPO1 pathway. We all have good anti-tumor proteins in the nuclei of our cells that ensure that the cells don't become cancerous. One of the ways cancers, in a particular myeloma, can grow is to expel these proteins out of the nucleus through the XPO1 pathway, and selinexor blocks that pathway so that the cell ultimately will die and will not become cancerous. Selinexor is given orally. Its side effects include fatigue, nausea, and vomiting, as well as a drop in blood counts. We now typically give this drug once weekly to reduce the side effects, and the drug can be given on its own or in combination with other classes of drugs. And this really is just the beginning, as many other classes of drugs are being developed in myeloma.